Uh, Thanks everyone, and thanks Rebecca for that build up. I'm always surprised when I get introduced as an expert or having expertise in co-production because this kind of happened as an accident. I've got a background in community engagement and community empowerment, and I was really surprised to find out what I was doing was co-production. It always felt like it was common sense and it was just the right thing to do. But apparently it isn't, and apparently there's quite a lot to be learned. And the position that I always take when I start on these discussions, and I think this is a really important position to take, is that in reality I'm not an expert in co-production. There are people who are genuinely experts in it, and I doff my cap to them. But I'm really experienced in co-production. And the reason why I never adopt that position of being an expert in co-production is for twofold. One, because speaking to a group of people assembled in this room, is that I know that there are people in this room who know as much, if not more, than me, even if you don't realize that you do, and do more co-production than you think you do. And the second thing is that as soon as you adopt the position as being an expert in co-production, you immediately put a barrier between yourselves and the people that you're trying to work with effectively. Because who needs an expert? What we need to be is people that work together. So we need to break down barriers, not build them up. So what that thing about professional expertise and I've got this qualification or that qualification is irrelevant in when we're working in co-production. So that's one of the reasons why I move away from this. And I'm going to spend as close to the deadline that's been set to me to talk about this, about strategic co-production. And I'm going to talk about insight from other systems, specifically around some work that I've been doing with 2 integrated care boards. So it's very much NHS. But it's not exclusively that. My experience is not exclusively with around NHS systems. Somebody needs to mute. So very quickly, I'm going to cover co-production in the context of individual, neighbourhood and strategic levels, differentiate those, look at system-wide outcomes, neighbourhood level activities, look at measuring benefits, and then we're going to put time, as Rebecca said at the beginning, to Q&A, where we start to ask some questions. So to get me through this, if you'd hold your questions or just type them into the chat as they occur to you. But I like to start things with some little co-production thoughts, and this is one of the things that I think is really important. One of the things that really sets the whole scene for co-production, and this is the fact that decision makers don't have to live with the felt consequences of their decisions. And decision makers always come back at me at this statement. And they say, of course, we live with the consequences of our decisions. If it goes wrong, we're the ones that have to report to our board about it. But what they've missed is that important, bolded part, the felt consequences. They don't feel the difference it makes in people's lived experience. And I think that's one of the things that we consistently see. One of the barriers that comes up from co-production is people who have the recent, when I say recent, I still think of it as recent, it's 2022, the NHS guidance about people working collectively. I've forgotten the name of the guidance now. I've been working with it for so long. I just think about it, people and communities. Talks has introduced a lovely phrase, which is about people with lived experience, which we're all familiar with, and people with learned experience. And that differentiation is really important, because we as professionals forget that our learned experience moves us away from that communities that we work with. And forgive me for making that broad generalization with this audience, and do push back at me about that later. But what brought it home to me was working in Northwest London with a member of somebody from that community, from a community that we were working with, who was working in the ICB or continues to work in the ICB, who came from the community, and it was a black community, and was speaking to the members of the community based on their experience when they lived there. And the community pushed back very strongly and said, "You're not from here now. You may have been from here then, but you now are, you've become middle class, you've got professional tenure, and you've forgotten what it's like, and things have moved on." And too often we think about it, base our thinking on those past experiences. So we need to recognize very much what we bring to the elements of co-production. And I just wanted to put our minds back a little bit to where it came from. Now, forgive me for doing this, but it's quite important to recognize where co-production comes from, because it's been around for a long time. So originally was first talked of, and you'll know this as an experienced group of co-producers, that it was first spoken of academically by Eleanor Ostrom with the famous case study of the Chicago cops and cars. And that was the first time that co-production was ever spoken about, which was when we removed the actual the police officers from the streets of Chicago and put them all into police cars. We actually removed an incredibly important resource to co-produce crime reduction. And actually we saw crime rates going up, which was exactly counter to what the intention was. And then we've got a huge period of time before we start to see the real implementation of policy co-production. 2000, we saw the publication of Edgar Kahn's No More Throwaway People. And it was before 2002, before we started to see things happening in the UK. Anna Coots, the IPPR, we started to establish things around the reciprocal relationship between doctors and patients. And 2012, talking about the health agenda, the publication of the Nesta co-production catalogue, people-powered health co-production catalogue. And the real reason for that was during the 1990s, we saw the kind of the market forces-led approach to public service commissioning, which is that the market knows what's being delivered, build it and they will come. And people were seen as passive consumers of products and services. And the people that make those services, know best. So here's your medicine, take it. We know what's best for you. And the real drivers, and you will know this already, the real drivers that made those changes were two really strong movements in the UK, which are the mental health service users and the disability rights movement. And that brings me on to a kind of another really important point, which drives us into the context of strategic co-production, which is co-production is not just another trendy term. It's not something that we just throw around. It's driven by the fact that it's enacted in lots and lots of legislation or statutory guidance. So in recognition of that change, that shift in thinking from the disability rights movement, the Care Act 2014 has co-production written right through it. Co-production it's got a very clear definition of co-production. Co-production is when you, as an individual, influence the support and service you receive, or when groups of people get together to influence the way the services are designed, commissioned and delivered. So that's right the way through the Care Act. So adult social services have to co-produce the way that services are delivered. You know that. And that's the way things have been delivered. So, and it's right the way through things like preparing the special education needs and disabilities, preparing the local offer, needs to be co-produced. Working in partnership with people and communities, the guidance that I forgot from NHS England talks very strongly, Principle 8 talks about co-production. And in the devolved nations, you've got the 5-year forward view for health in England, Social Services Wellbeing Act in Wales, Public Bodies Joint Working in Scotland, and Social Care Self-Directed support in Scotland 2013. All of these acts and statutory guidance talk about co-production. So co-production is not just the right thing to do, but now it's becoming a statutory duty. We have to do it. And I wanted to just bring us on to the definitions. I think local act personal provide us with this beautiful ladder, which is flawed a little bit because it falls back on Sherry Arnstein's ladder of engagement. So it talks about doing to, doing for, and doing with. And in this, we're looking at doing with. And I'm not going to articulate because we're a bit short on time, but I want to just draw your attention to the top of the ladder, the doing with, the differentiation between co-design and co-production. Co-design talks about people who use services and are involved in designing services based on their experience and ideas. They have genuine influence but have not been involved in seeing it through. And co-production is an equal relationship between people who use services and the people responsible for services. They work together from design to delivery, sharing strategic decision-making about policies as well as decisions about the best ways to deliver services. So in terms of strategic co-production, really important definitions that sit there. And we talk about co-design and co-production sometimes interchangeably, and that gives us a clear differentiation between the two. Co-design takes us up to the decision point. Co-production takes us into delivery. Very often, though, we think about the delivery is actually that takes us into the actual hands-on delivery. But TLAP have given us a very clear, nuanced definition, which talks about the strategic direction and decision making, so that the people who are involved in the co-production, people with lived experience, are involved in the decision making and a direction of decision afterwards. So that's really important as we come through. And another way of looking at that is just to shift it on its side, so it moves us away from that kind of thinking about ladders. And another thought that I think is particularly important, particularly when we're talking about strategic co-production, is about power sharing. And this is a very important message for those people who come from this with the from the learned experience. So I join in a number of communities of practice like this, and there was one practitioner who had that lovely sense of self-awareness and came up with a statement about themselves, and they said this: I thought I was sharing power, then I realized that I was setting the agenda and asking all the questions. And that is about having a nexus of power and control instead of working with the people that we should, to say what's important to you, what are the important questions. So we don't have an open debate, we don't have an open discussion. So it's actually talking about that. I've just seen that in the chat, by the way. I will share a copy of these slides for everybody afterwards. And one of the important points around this, when we think about strategic co-production, is the principles of losers' consent. And when we talk about co-production, it's a form of participative democracy. And that's essentially, when we play the game, somebody always loses. And so that's an unequal outcome. And I used the analogy of Sunday League. It's a bit of a kind of a niche analogy. But if we played Sunday League football, and every time one of the sides lost, they decided that they were not going to play any further because they didn't think it was fair to them, we'd soon run out of time for a Sunday League. So what we need to actually talk about is the 5 minutes, Rebecca. Yeah, okay. Yeah, I've got 5 minutes, so I'm going to belt through this. So actually what we do is we need to develop the principles where people come out with this with a feeling of fairness around that. A couple of things we do to get this: agree the scope up front, work together to develop appraisal criteria, and work together to co-appraise it. So that's a practical way in which we can apply those principles to strategic co-production. And the Frank principle is very much about the principles of fairness. So it's about ensuring that we feed back everything as we come through this. And the whole principles of ethics start to apply there. And we can talk about that as we get into the questions and answers. What I'm going to talk now about is system-wide and neighborhood level and individual levels. So there are this triangle, this pyramid actually sums it up really well. Individual co-production is what we see in the kind of level of co-production that we see in adult social services, where the co-production that goes on is determined by the co-production that goes on in the delivery of an individual care plan. Group co-production is where we work for a neighborhood and community. So we care for the neighborhood and communities. And strategic co-production is where we look at for organizational and strategic priorities. So there's different layers of co-production. And I think that's a really useful way of differentiating it, because it starts to unpick that confusion, because we start to think about, we talk about co-production as if it's a kind of lump and mass. It's the same way of doing it. It actually, it unpicks and unpeels. Talk about system-wide outcomes. Two case studies, Northwest London and Greater Manchester. I'm going to go through the Northwest London. So the Northwest London approach to co-production, they've taken that through their health equity program, at which they've looked at they've developed their approach to population health management, and they've put 5 enablers in place: analytics, engagement, co-production, leadership and facilitation, and health economics, value-based care. And they've actually taken a system-wide approach to this, to co-production. And what they've done is that they've enabled an ongoing staff training approach, where they've taken the entire, if you like, customer-facing or community-facing staff, put them through a training program, which leads, and it gives them the skills and aptitude to approach co-production. And then we're starting to see that being delivered at neighborhood level, where we're seeing one specific example that I'm working with them on is in Hillingdon and Hounslow, where they're working with 3 specific programs: refugees and asylum seekers, asthma in children and young people, and maternity among South Asian and Black populations. The approaches are 3-phase. So the first is to work with those cohorts to recruit them. Then working with the local VCSE groups, then they're working on that. Then I'm working with them to train them, the cohorts, around giving them the skills around co-production, some of the basic approaches to it. And then we're working together to develop, to deliver their interventions directly, co-production interventions. And we're working on some very simple projects. And this is delivered by underpinned by the focus on methodology that is working at that population level. So that's going to run through this very quickly. That's find areas of inequality, open conversations, co-create ideas, unite co-design groups, study impact, and then go to ongoing measurement. So that's the way Northwest London deal with it. And Greater Manchester have taken a completely different approach to this. They're slightly further behind the whole the Northwest London approach. So Greater Manchester ICB is acting as the facilitator for the system-wide approach. So the first stage is they convened professional discussions. So that was working with the NHS organisations, combined authority, and the VCFSE, can never say that in the right organ, those discussions, and he developed a set of initial principles around co-production, but recognizing that was not co-production, that was just an internal conversation. Second stage was to develop a Manchester-wide World Cafe event to develop those principles further and to develop an action plan. And from that, 2 further stages are planned. So running locality-based neighbourhood events to plan local approaches, and then taking that back to the strategic commissioners, to NHS Greater Manchester and the combined authority, to agree how they will have their strategic and operational priorities for co-production sit within that. And I was also asked to talk, so I'm going to pinch a bit of time, Rebecca, just after this. I'm going to just talk about measuring benefits. I'm going to flash through this. So when it comes to measuring benefits around this, we're asked all the time, what are the benefits for co-production? And I've got 2 kind of avatars that I think of that I want to convince around this. One is somebody in the local authority in public health, specifically somebody in epidemiology, who looks at the spread and the numbers, very, very statistical approach to things. And the second is somebody in any finance department. So how do we provide empirical evidence and financial evidence to it? And I've got to say, the evidence base for the value of co-production is weak, generally. There's not a lot of it. Lots and lots of anecdotal evidence of the benefits of it. But in terms of convincing it to those 2 stereotypical avatars, there's not a massive amount of evidence. And the tendency for that is that people, when they come to projects, tend to neglect the baseline. So by the time they've finished, they've forgotten where they started, so they can't measure. And the second thing is that when they do come to make it set baselines, they make it too complicated. And that's where a lot of it falls down. But where it does exist, it's really strong. And I just want to go through very quickly. It's quite dated, quite old, but this is a really strong example of the benefits of co-production that we can take back to those 2 stereotypical avatars that I talked about earlier. So this is the Partnership for Older People projects. This is nationally funded by the Department of Health, range of projects between 2006 and 2009. You may have been involved in some of these projects. And it was 146 pilot projects across England. And the objective were to reduce hospital admissions and improve older adults' well-being. And the focus was on early support, early interventions amongst older adults. The difference in this approach was, instead of being a kind of a top-down, centre-driven approach where we're going to work with older adults and we're going to do this, we're going to do that. So moving from that, doing 2 and doing 4, this became a doing with. The key part about this was that older adults were involved in the development. They were at the heart of the partnership. So co-production was at the heart of the partnership. So it was the NHS, local authorities, voluntary community sector, and critically older adults were involved in that, in themselves, in the development of these projects. And it became true co-production, not co-design, because they were involved in the decision making and delivery. So they became members of steering committees, program boards, participated in recruitment. They became volunteer workers and helped in project evaluation. So I remember going back to that ladder that I shared earlier, and the reason for sharing it was so I could throw back to it, that TLAP have developed. The definition, or the difference between co-design and co-production, is when people are involved in the direction of the strategic direction of the delivery. So even if older people weren't involved in directly delivering it, they had a direct hand in the strategic decision making of it. And what it showed us, the key outcomes of it, that was a 47% in reduction in the hospital stays and 29% fewer A&E visits in areas where these projects were in place. There's a £1.20 was saved for every £1 invested. 97% of projects continued after funding ended. There was the quality of life indicators, improved patient experience. We had workforce efficiency and reduced complaints. There were challenges to that. If it worked really effectively, we'd still be seeing them. And a lot of these things have fallen off the table. But the sustainability was one of those issues. The evaluation and the complexity of the evaluation and the cultural shift that was required in thinking were big challenges in it. But the overall lesson in this was that investing in co-production leads to financial savings and better care quality. I'm going to flash over those things, and we're going to go to Q&A.